So what we use commonly are semi-synthetic cellulose derivatives, methyl cellulose and carboxymethyl cellulose. So these are demulcents. They are slightly makes the tear film more viscous. It retains the tear film for a long period of time, and there is less friction on the surface. Host of products are available, and among between HPMC and CMC is a better mucoadhesive, but in general, both are almost similar. And among the synthetic polyvinyl polymers, these are slightly different mechanism of action. It works like mucin. It attaches to the epithelium and basically makes the surface more smooth. That is the polyvinyl alcohol, povidone, and polyethylene glycols and all that. So it lowers the surface tension, and that's how it stabilizes the tear film. So certain products like Sustain, I don't have any commercial interest, but I just want you to know that these bind to this HP GOR is there, which binds to hydrophobic sites, and there are active demulcents which are there in the surface. HP GOR keeps all together, and it provides a extended protection. So there are even among the so-called Sustain, there are multiple things that is available. So much more confusing. And in Sustained Balance, you have, along with that, lipids are also present. In Sustained Complete, you have electrolytes also. So in osmoprotection, what you mean is there are small hydrophilic osmotically active substances that modify the cellular water intake. It basically prevents against hyperosmolarity or hyperosmolality induced HRA. So there is, as osmoprotectants goes into the cell, it is the increased duration of action of the dimers can be expected. So there are different type of protectants. I think a few are available in the market. Erythritol, glycerol are well-known things. Trehalose is there, sorbitol is there, L-carnitine is there. So when you have a normal cell and when it is exposed to hyperosmolar environment, it gets dehydrated. In the initial period, it is reversible. So if you have, if you are using osmoprotectant, it's more likely to come back to normalcy than if it goes to a permanent state of damage. If it goes beyond a certain stage, there will be apoptosis and cell damage, which is irreversible. So there are these solutes, what we say, these are having multiple ways of entry into the cell. So glycerol has a passive diffusion, while erythritol also has a passive diffusion. L-carnitine has basically it through amino acid transport mechanism, it goes inside the cell, and that is an active transport mechanism. So these are two slides comparing the action of MMP, that is a collagenase, that is an inflammatory marker on the present on the cell at different osmolar concentrations. At 312, which is near to normalcy, it is not there. But if you go to 450 milliosmolar, the amount of inflammatory markers go up. But if you pre-treat the patient with L-carnitine and erythritol, the inflammatory markers are slightly less. So there is another compound, trehalose, which is again useful. It is disaccharide protective. It also forms a gel around the cell organelles, and it is supposed to stimulate autophagy, and that's how it protects. So there is a good paper, randomized controlled trial. I'll take one more minute from our All India Institute in Jodhpur, in which they have done a reasonably good study, and they have found that trehalose, along with sodium hyaluronate, is quite useful. So, but we have to understand that there are a lot of ion channels in the dry eye, which we have not really come across. This is one of the recent papers which came from Narad Nethralaya. They found that a lot of channels are there. The red ones are action which causes dry eye features. The blue ones in action resolves the dry eye features. So, a lot of channels are there. If you just see the action of few channels and few molecules get into that doesn't work that way. So it's a much more complex mechanism. We have just made baby footsteps there. The other important category is the humectants, which involves hyaluronic acid. It has got a good mucoadhesive action. It has got a reparative process also. It attaches to CD44 cells, and it has known to cause healing process of the epithelium. And hyaluronic acid CMC combination is a good one. And there is a meta-analysis which tells that the combination is really useful. I think a lot of options are there nowadays. I think one of the things which are not available in our market is one is decofazole and rebamipide. I think these two drugs are very effective. Actually, it is there in the Japanese and Korean market, and it is doing very well. So, in the interest of time, I'll just say that it increases the tear lipid thickness and increases the objective and subjective scores. And if you combine diclofenac with sodium hyaluronate, we know that it is much better than using sodium hyaluronate or any other agent. So I think if you compare with the data which is coming from the West, and if you look at the data which is coming from the East, the Japanese data appear more appealing to me in that there is a target for tear film oriented therapy in which there is a significant type of short breakup time dry eye, which is very commonly seen in our context. And in such people, declofenac and rebipamide are very good agents. Thank you so much.
Thank you, Anil. That was a very informative talk, and he had summarized everything. And last few slides were particularly very important. He had summarized what is happening when there is hyperosmolarity, and when will you choose an osmoprotectant, dry eye, and lubricant. And we will be dealing with more in the panel discussion. So we have one more young speaker. He will talk about the latest management of MGD, meibomian gland disease. He is none other than Dr. Madhu Udaraju from Vizag. And I welcome you, Dr. Madhu, for this session.
Thank you, ma'am, for making me part of this session. And thanks, Rini, sir, for inviting me to this Golden Jubilee celebration of KSOS. So I have no financial disclosures. So the scope of this talk would be under the following headings. So if you see, meibomian gland dysfunction is a chronic and diffuse abnormality of the meibomian gland, and it's commonly characterized by a terminal duct obstruction with a change in quality and quantity of the glandular secretion. If you see, this is how the meibomian glands look normally. That's the upper lid and lower lid. In upper lid, you have 25 to 40 glands that are around 5.5 millimeters in length, and the lower lids are shorter with the lesser glands of 20 to 30 glands.